everybody. As I said, my name is Marco Staffney. I'm the Executive Director of the Montshire Museum of Science and your host today for Health Research Live, Understanding Community Health. How do we understand and address community health needs in our local area? Well, every 3 years, a number of community health partners in the Upper Valley facilitate a community health needs assessment. This contributes to a community health improvement plan that guides numerous organizations to address relevant health issues. Today, we'll learn more about community health needs assessments, how organizations use these to affect public health in our area, and how to participate in an upcoming assessment. Joining us today is Elizabeth Crape, the Director of Community Impact for Granite United Way, Alice Ely, the Executive Director of Public Health for the Public Health Council of the Upper Valley, and Greg Norman, the Director of Community Health Improvement at Dartmouth-Hitchcock Medical Center. So how does today work? Each presenter will talk for about 10 minutes, and then we'll be breaking up into virtual Zoom rooms so that you can have smaller group discussions about what you've heard for that 10 minutes. Then we'll come back for a broader Q&A that we'll host through a chat feature. So with that, I'm going to invite Greg Norman up to the virtual stage to come on, and I'm going to spotlight him for everybody. And Greg, if you wouldn't mind sharing your screen for your presentation.
Great. Hello, everyone. Many of you I know, some of you new to me, but looking forward to being able to talk with you today. So just to give you a little bit of insight into what community health needs assessments are, my definition is that it's a process through which we listen to and engage with communities fundamentally, that whether we're hospital-based or whether we're public health-based, that it's critical for all of us to take the time to engage in dialogue in terms of understanding information about communities and being able to combine kind of some of the data that we know about communities with what we hear through conversation and through responses to questions from our communities to form a picture of what's happening that impacts health in our communities, and that we shape that using some kind of a model of health that's based in some broad theory. So frequently, we would use what's called the social ecological model of health, which really says that people's health is determined partly by what they do, partly by the families and friends around them, partly by the organizations and systems in the communities that surround them, partially by environments and sort of bigger factors that impact them, and at a highest level by public policy. And that to understand health, we need to look at sort of all of those different domains to understand what's happening in a community. So community health needs assessment process really is trying to look at all of those kind of domains, gather a large amount of information, both quantitative and qualitative, and then put it together to try to create a picture of the communities we're in. And there we go. And the visual that I like to use a lot is on this slide. It's fairly complicated, but really the circles in the middle are the part that are most important. Community health needs assessment process usually engages 3 or 4 different kinds of data gathering tools. So in the lower right-hand corner, we utilize common public health data and health data approaches that are quantified. So, there are a lot of reports available about, say, prevalence of different kinds of diseases in a community, about hospital discharges, about prevalence of tobacco use. So many different things that are collected by systems that routinely collect data using the same kind of questions and provide very reliable quantitative information that can inform us about health issues in a community. Along with that, we want to partner that with a couple of types of surveys. So we do, on the upper left, we engage in surveys with who we think of as key community leaders. And key community leaders are people that we define as having a big view on what's happening in a community. People who may be less connected to one individual cause or one individual disease condition or public health issue, but who really have sort of a broad look at their communities. So a common key leader might be somebody who's an emergency services leader who's responding to multiple different kinds of crises in a community, or a town welfare officer who, again, is experiencing people with multiple different challenges. And through that process of understanding multiple different challenges can say which things are happening most often and which things are happening less often, and what do we see all the time that we wish was different. We then partner that with a survey of residents. So we want to know not only from a leadership perspective, but from the resident, the perspective of people who live in our community, how they see health and well-being around them. We tend to, in our Upper Valley process, use what's called a convenience survey, which means anybody can access it. It's not a random survey that's sort of scientifically designed to capture a snapshot of our community based upon different demographics, but really is open to anyone to offer their thoughts and comments. And then we partner that with what we refer to as community discussions, which tend to be very specific subgroups of our population who may not otherwise be easily heard through some of our other methods. So resident surveys are either written or they're online. Somebody who doesn't have a high literacy level may not be able to participate in a resident survey. We want to engage those people in some kind of a discussion group or other format that's more adaptive and more informed to be able to understand their needs as well. Similarly, we may look out to groups who either through discrimination or through stigma may have unique experiences of the community and sort of understand those stories through a more direct, interactive small group discussion. All of these tools have different strengths and weaknesses. And I think, what I tend to think about is that each of these are a window on our community. We can combine that with what we read in the newspaper. We can combine it with reports that we see from a regional planning commission or other sources. And then at the end of this process, we ask ourselves, does the data that we gather through each of these processes look the same? And if not, why not? So, we may hear in a key stakeholder survey that falls among older adults or critical in communities. We may hear something a little different when we get surveys from community members, and we may see similar trends in our secondary data. So we're really trying to pull together multiple types of information and create a common story. Just some examples, we look at things from a demographic standpoint in terms of household income by communities, the number of people living in poverty in different communities, building some comparisons with the state or with the local region to see how income impacts people in different communities. We may pull specific health behavior indicators like binge drinking in the past 30 days to look at differential rates of substance use in different parts of our community. And then from our community survey, we may look at questions like, if you weren't able to get access to care, weren't able to get access to a service, what were the barriers that kept you from being able to reach that service? And looking at multiple different reasons and trying to understand what are the key things that prevent people from being able to access what they need. And then again, from a standpoint of like a community discussion group, we may meet with, in this case, a group of women who are recovering from substance use, who have either parenting or pregnant with young children, and understanding their needs through a more verbal narrative process. When we do that, that process of looking at all those different windows, 3 years ago when we did this, these 5 issues really kind of rose to the top of our needs assessment platform. So substance use and behavioral health, which has been a critical need for multiple assessments at this point in time. Say a significant increase in people defining that financial insecurity, housing, food, transportation needs, sort of basic fundamentals of life were beginning to rise to the top. And again, an increase in people talking about issues of trauma and violence, whether it be physical and sexual abuse or whether it be child abuse, was an issue that kind of showed more clearly in our last cycle of needs assessment than it had previously. And then continuing concerns around sort of how we're mobilizing as a community around the needs of older adults, and continuing challenges around health and access to healthcare, and particularly to prescription drugs. So we take this, this in the center of the circle is what we showed before. We then take the findings of our needs assessment and we engage in conversations with community organizations, other community stakeholders, and begin to, through those discussions, try to make meaning of what the data in our needs assessment is telling us. And from that, begin to engage in plans. So at the hospital level, we have what's referred to as a CHIP, or a community health improvement plan, where we begin to mobilize our budget and sort of our academic experts at the hospital and other resources that we can bring to bear to try to address community dynamics that have been raised in a needs assessment. But also that, this material then becomes available to other groups in the community who can similarly begin to use the findings of the needs assessment to think about their own planning processes. And I'll pause at that point.
Great, thank you so much, Greg. I'm going to pass it on now to Alice. Alice, I'm going to ask you to share your screen, and I'm going to spotlight you for the group. Alice, it looks like you are good to go.
Great, thank you. I'm trying to make sure I can do this as a slideshow. There we go. Okay, so thanks, Greg. That was a terrific overview of the process, and I certainly don't want to repeat what Greg said. I do want to start back just a step and let you know what the Public Health Council is about, why we're here, and why this whole process of community health needs assessment matters. So the Public Health Council was launched in response to New Hampshire's calls to establish some regional public health networks back in 2013. They used funding from a couple of different program areas to allow these networks to build some capacity. And they also asked our regions to take on the role of creating regional community health improvement plans and coordinating their implementation. Each region built their Public Health Advisory Council in a way that really suited that region. So in the Upper Valley, we've created a broad coalition of partners guided by an advisory council of 14 to 18 people representing diverse sectors across the region. We have, and I'll move on, we have a mission that's really focused on this question of improving health, using our network of partners working together. And as you can see from this map, we have expanded to include a number of communities on the Vermont side of the river, because there was early on a recognition that just focusing on folks within the New Hampshire side of our Upper Valley region was really not reasonable. People in our communities live, work, and play on both sides of the river every day, and the organizations that serve them also cross the river and work very, very much together. We have a mailing list of well over 200 individuals from organizations across our region. These represent municipal folks, organizational folks, advocates for particular issues of concern, and people who just want to be plugged in. And fortunately, we have a base of more than 40 organizational partners. Our advisory council, as I mentioned, is really designed to make sure that it has representation from many, many different sectors. Because of course, one of the goals that we have here, and one of the powers of something like this coalition, is that we really work across silos. We try to make sure that the people are coming together to look at any particular issue from multiple perspectives, so that we better understand how that particular concern plays out in the community, but also how we can leverage our resources to do something about it. The way we operate as an organization is essentially to do in many ways what Greg described in the community health needs assessment process. Listen, create a shared set of priorities, figure out how we can work together, and focus attention on those underserved areas of our community, those underserved issues or populations that we want to make sure we're not glossing over as we figure out ways to address them. So as Greg described the community health needs assessment process that Dartmouth Hitchcock leads with hospital partners from around our region. I will say that the Public Health Council tries to be helpful and a partner in that process from the very beginning. We certainly help with the community conversations piece and finding folks that can talk about their own experiences. We work with them on getting the survey out. And then also, as Greg described, that process where you bring stakeholders together to say, this is what the data looks like. What do we make? How do we make sense of it? The Public Health Council has been a part of bringing those folks together, using our partnership networks to drive those conversations. So up until the point where the community health needs assessment is released as a document, all of the things that Greg said are exactly the things that that happen, and we like to think that we're involved in. But then what happens at that point is really where I'm going to pick up at this stage. Greg described priorities that the hospital system saw from that community health needs assessment. Our partnership came together, and we were looking at the same data. We were looking at the same information. We adopted many of the same priorities, but in some cases, we looked at those priorities in slightly different ways. The question was, what is it in this document that the partners we have within the community setting, municipalities, social service organizations, and others, what are the things that we can do something about? And so over the course of nearly a year after the document was released, we brought together subject matter experts to really dive more deeply into particular issues. And I'm going to walk through one of those just briefly in a moment. And then we figure out what are going to be the best strategies. We look at what's already going on. We look at opportunities to leverage things that are happening, particularly if something really great is happening in one part of our region. Let's say, for example, the Mount Ascutney Hospital is leading some really great work. One of our strategies might actually be to find ways to share that work with other parts of our region, find other partners who might want to do those same things. In some cases, it's to pilot new approaches, or sometimes it's to bring new groups of people together to figure out what they think they can do to address this particular problem, especially, again, across the silos. And then finally, we do establish goals and objectives for our community so that we can look back and get a sense of how well we've done to reach those goals. I would love to say that the plan we put together in 2020 was going to meet all of the goals and objectives we set. Unfortunately, the COVID pandemic has put some of that work to the side because we're doing one of the core public health strategies, which is respond to a global pandemic, which of course is work we need to be doing. So Greg mentioned trauma, and one of the things that emerged from that community health needs assessment, of course, was this issue of child abuse and neglect. And the data showed that there had been increases, and community concern certainly brought this to the front. So when we gathered people together to talk about this issue, we presented them with snippets of information, as you see on this particular poster that was used. We had a gathering back in, I think this was from January 2019. People came together, and this was a group that spent half an hour or so really talking about this issue of child abuse and neglect and saying, what are we doing? What's here already? What's missing? What are the things we can build on? What are the things we need to build in? And it was from that we started to develop this sense of exactly what it was we could be doing. And this is an example from this family strengthening goal area of the kinds of strategies that we established for working on this issue. So bringing together more folks across the region into a network so that there was more awareness of issues around child abuse and neglect, working with our partners at Dartmouth Hitchcock and other places to really build out more trauma-focused family strengthening projects, and again, look at ways that they could be replicated in different areas. continue to work with schools to support the non-academic needs of students, food supports, and then continuing to help all of the network partners think about how social determinants of health are core factors in addressing health issues for their clients and looking for ways to screen for and address those particular issues. Just wanted to share the priorities that were established within the Public Health Council for the 2020 Community Health Improvement Plan do range from family strengthening, gender-based violence, altogether is a substance misuse coalition in the region that looks both at prevention, intervention, and treatment. We always look at mental health care. One of the things that makes the Public Health Council's approach a little bit different maybe from the hospital's approach is that what we're thinking about in terms of mental health care is not necessarily can we create more beds or can we create more providers, slots for people who need treatment. We're thinking about how do we make our community more supportive of folks who are living in our community with mental health challenges. So what are the trainings that can be done for suicide prevention or mental health first aid? How do we work with police departments so that they are more responsive to the folks that they encounter who are actually in mental health crisis more than they are exhibiting criminal behavior? And as you can see, there are a few others there that we work on. Some of these persist over time. They were the same priorities we had in our 2017 plan. Some of these priorities emerged as new concerns in this last round. And when we go through our next round, we'll be interested to see sort of what's shifted and changing over time, but we'll be ready to respond to those as well. Thank you very much. I think that's my last slide. Yep.
Great, thank you so much, Alice. And now we're going to move on to Elizabeth. Elizabeth, I'm going to spotlight you for everybody. So you are in the screen for everybody.
Excellent. Thank you so much. And thanks for inviting me to join the group today. The Community Health Needs Assessment is an exciting document for me, coming from Granite United Way. It's important for our staff to be in tune with the needs assessment for the Upper Valley region and really for all the regions that we cover throughout New Hampshire. It gives us an idea of what the community needs, what the community wants. I mean, there's certainly nothing worse than going into a community and saying, hey, I have this great new program to offer, and have it be something that the community doesn't really want or feels that they need. But more importantly than that, it's a great tool that we use with our volunteers. A lot of folks don't know that the United Way is largely volunteer driven. All of our funding decisions come from community volunteers, and the priorities that we look at in our communities are driven largely by our volunteers, with certainly some support from our staff. So the Community Health Needs Assessment is really vital to that. It's not the only tool that we use when looking at community priorities, but it's certainly a very important one, and we urge all of our volunteers to access and there's several. Manascutney provides one, Dartmouth Hitchcock. We encourage them to read them to really get a better understanding of what's going on in the community. I think that volunteers come to us with their own personal interests and passions, and this sort of kind of gets them out of what we call it, sort of their silo of thinking, and really look at what's going on in the broader community. And I think every time a new study comes out, there's surprising things on there that we don't realize, that there are gaps in our community that aren't being filled. We have the committee that helps set our priorities in the Upper Valley is our Community Impact Committee, and they are encouraged to use the needs assessment every year and regularly to keep check on what their work is and what the priorities are in our region. Our next grant funding cycle at Granite United Way is going to be in the summer of 2022, and we are going to share this with the many volunteers that we have who come to evaluate the grant applications. Last year we had 30 volunteers from the community, and we encouraged them to use this as a tool to just better understand what's going on in the community. We also use it as a way of developing our next grant application. So we take a look at this, and we use it to craft what that application is going to look like, what questions we ask, and that sort of thing. But beyond funding, the needs assessment has been used to craft interesting initiatives for Granite United Way. One example here in the Upper Valley that came out of the 2014 Community Health Needs Assessment was our Work United initiative. That needs assessment, through that we found out that one of the groups that was really most left behind in our region were low-income wage earners and their families. And what this was causing was problems at work, poor low job retention, poor performance at work. And so we partnered with companies here in the Upper Valley. Right now we work with 12 different companies here to put resource coordinators on site in their workplaces to help their workers deal with problems outside of work that could be keeping them from doing their best job at work, or even keeping their job, retaining their jobs. And as our resource coordinators have worked over the years at these different companies, the community health needs assessment findings are proven out year after year. The issues that come across the desks of our resource coordinators are exactly what are outlined in the needs assessment every year. There's, they see domestic violence, they see legal issues, they see folks needing assistance to access to health care, child care issues that are keeping them from doing their best job at work, access to transportation, access to food, are all issues that come up and are proven out again and again. It really comes full circle. And then as we participate as an organization with the different health networks in crafting the community health improvement plan, the CHIP that Alice and Greg were just talking about, we can bring those concerns back and say, yeah, these are still problems, and this is sort of what we're seeing on the ground here in the Upper Valley. Another great initiative that came up in our Manchester region was the Youth Enrichment Partnership. That came out of their community health needs assessment, where they saw that there was a community issue around safety, income gaps, and specifically mental health for youth. In this case, it was this Youth Enrichment Partnership focuses on middle school kids. And it brings together funders, schools, community organizations, churches, nonprofits to come together to create programming that is affordable and accessible for all the youth in Manchester. So in both cases, the community health needs assessment informed our volunteers as to the needs of the community and really helped them set priorities that were appropriate and welcomed in those communities. And like I said, we're actively involved in coming up with the community health improvement plans in each of our regions, so that we can bring real and appropriate help to folks, to the people that we serve. So I'm going to pause there as well.
Great, thank you so much, Elizabeth. I'm going to place a spotlight with me. Hi. So now comes the time in our program where we sort of ingest this information and take some time to talk amongst ourselves. Okay, it looks like the majority of us are back. I don't know if I'm being spotlit or other people are being spotlit, but you might want to just go up to your view button now and just click gallery view. That way everybody can see everybody as we come back into a larger discussion. Thanks so much for having those quiet discussions. I was able to be a fly on the wall on one of them, and it was a really riveting conversation about the effects of the pandemic on community health needs assessments and community health. I'm sure that probably was in many of the groups, and how do we discern the differences between issues that were happening before, issues that were happening currently, and then issues that will happen out into the future. We had one really specific question come up in the chat, and I'd love for one of the presenters to address it. Are local agencies looking at other communities across the country and or region to consider successful programs that have worked elsewhere? If so, any creative ideas or solutions that you can report on? That it might be a question for actually any of the presenters if you're looking outside for other community health needs assessments and work being done on them.
Greg, do you want to say anything?
Well, I think I mean, I think all of it. So, and first of all, keep in mind that, you know, Alice and Elizabeth and I and many others are all sort of multiply intertwined between our roles. So we're pretty constantly interacting in this region, but we also have networks, you know, through sort of the public health systems in New Hampshire and Vermont, through organizational networks on both sides of the river, and then through different national organizations. So yes, we do sort of have ways that, you know, we're scanning and looking for best practices elsewhere. You know, I think what we try to balance on a regular basis is, you know, we will meet with, you know, local organizations and local community members around an issue. We can begin to say, like, here's some opportunities, you know, here are things that have been done in other communities, but frequently, you know, a sort of local decision-making group may have a more localized or more immediate kind of project that they're interested in. So there's an ongoing conversation that happens over time about sort of what level of new activity we want to engage in, sort of whether we're drawing from sort of whole programmatic, you know, pull-ins from other communities, or whether we are sort of putting expertise and ideas together locally to create solutions that are well suited for this particular community. You know, I would just give the example of, you know, the community nursing work that's happened in the Upper Valley has evolved largely organically. There are other community nursing projects and models that can be built from, but it's been developed in multiple communities here. It works locally. It's well suited to our particular rural environments and the communities that support these nurses. And so rather than try to bring in sort of some different model, I think in many cases what, you know, Alice and Elizabeth and I would say is that, you know, we try to say, how are the ways that our institutions can support and nurture, you know, these sort of locally successful and locally viable interventions through technical assistance, through, you know, helping with technology systems, through, you know, in some cases, contributions of you know, dollars to be able to support program development in different ways. So I think there's this interactive process between what we evolve locally and sort of ideas that we bring in from other communities. Alice or Elizabeth, do you want to follow up on that?
I mean, I would say from United Way perspective, I mean, we get a lot of inquiries from other communities about the programs that we offer, you know, specifically Work United, other communities that want to bring it to their area, which is exciting to see it sort of spread out across the country. But we also have a great network of resource coordinators across the state of Vermont. And our resource coordinators here get together with them. They try to get together quarterly. It was in person, but now they do it via Zoom to just compare notes and see how they can improve the programming that they're already offering. So there's a lot of collaboration going on.
I think that Greg really said it well. There's always a balance between looking at exactly the way someone else has addressed a problem in another part of the region, another part of the state or the country, understanding what their particular strengths and weaknesses are as those compare to our strengths and weaknesses, and figuring out whether it's something we want to adopt as a model or whether there are lessons to be learned from what they've done that we can take advantage of here. And we've done all of those things. And sometimes we learn lessons about what not to do, which is often just as valuable. So yes, there's always this sense of scanning. And of course, we have so many partners, and those people are the ones that are scanning the environment in their particular areas of expertise and bringing ideas forward. And then we vet them with people who are looking at that particular issue from a very different perspective. And again, I think that really helps us to narrow down what is it that's going to work best in our particular Upper Valley region.
Great. It's interesting to see the strands of conversations that have happened in the different groups coming up into the chat right now. And what I'm seeing are a lot of interesting questions about older adults, but I'm also seeing some particular issues with long-term effects, for example, of online learning and childhood. So older adults and childhood are two community health needs that were addressed in the past, right? There were different types of issues that were addressed. How do we think that this community health needs assessment that's coming up is going to differ from the one or the ones prior?
So you're asking for predictions of the future.
Right.
We're about 10% of the way through this particular cycle of a needs assessment. And I think I can only speak from experiences over the last year through like the public health networks in the region, through Upper Valley Strong, Greater Sullivan Strong, which are sort of broad networks of organizations addressing issues related to COVID response. Social needs, so people's ability to meet basic daily needs of living, the food that comes to their homes, their ability to get transportation to where they need to go, the lack of social connection that people have experienced for the last year, the impacts of that on depression and other mental illnesses, I think will be pretty profound. There'll be a pretty loud voice in this upcoming needs assessment. And, there will be a point where, we will achieve somewhere close to herd immunity from this virus itself. But that won't restore a year's worth of lost social connection for whether it's older adults or whether it's young children. It won't replace the job income that's been lost, and the fact that people have had to go into debt or remortgage their homes or lose some of the wealth that they had accumulated previously to support their lives. So I think, that I would have to imagine that that's going to be the loudest voice that we hear in this particular cycle. As much as we'd like to be visionary about other health needs, I think there's going to be just a call to restore sort of the basic functioning and the basic support systems that assist people in being able to meet their basic needs.
Greg addressed that question from the crystal ball perspective, and I think there's nothing that I can add to what he said. I think he's right on target. But I actually would like to address that question from more of a process perspective, and want to give Greg and his partners at Dartmouth Hitchcock a tremendous amount of credit for what I think has been a growth in the way that the community health needs assessments are done in the last 10 years or so. And I think that the advancements have really made a difference in terms of how our various communities are able to use this information. Back 10 years ago or so, each hospital did their own community health needs assessment. And that includes, and I can't recall whether APD and Dartmouth Hitchcock participated together back then, but New London Hospital did their own, Valley Regional, Mount Ascutney, all these other. So there were multiple documents. The visiting nurse associations did their own, and they asked their own questions. There was no consistency necessarily across these assessment processes in terms of what it was they were looking at, what kind of information they were gathering, and how they were using that. Greg has played a real leadership role over the last 10 years of bringing those partners together to say, hey, if we did this consistently across the region, if we used the same data collection tool, if we asked for the same information from secondary data, if we did these focus groups or community conversations on the same topics with people from across the area, how much better would our data be? Would we be able to say, that one community as compared to another community, we can figure out where the strengths and weaknesses are across our region? And so for the last couple of cycles, we've done this as a unified process across a wide region of the Upper Valley and beyond. And so one of the ways that it differs this time around is that we're digging even deeper. We're doing more of these community conversations. We're looking more deeply at pieces of data that maybe we didn't have 10 years ago, because it's more economic process when you're doing it across a broader region. So I do want to give Greg credit for a process that's getting better and better as the years go by, and I think giving us much more powerful information to work with.
Any last thoughts? We're just at the end of our time here. Elizabeth, any thoughts about so a original question of what's different between now and the future?
Now, our group was talking about this a little bit in the breakout session. You know, obviously you can't predict, but we're wondering if it's going to be new issues that we hadn't occurred to us, or if it's just going to be a magnification of the list that is already there.
One last question that has come in that I think is a good way to make this our last question, which is that the community collection of community data is incredibly important work. In diversity, equity, and inclusion committees, we are identifying the collection of population and service gap data as being a major goal for resolving health equity differences. How will the next community needs assessment work to collect fully rounded human perspectives on the next round of collection? What are the strongest tools for representative data collection or community conversations? Anyone like to tackle that question?
In 2 minutes?
2 minutes, you have 2 minutes.
So in the short term, I would say probably the biggest challenge of the needs assessment process we have in this region is that it is stuck in a large population problem. It's very difficult to be able to engage, gather data at a meaningful level about, small micro populations in our region. So, we know that we don't have an adequate differentiation of information about Black, Indigenous, and other people of color who live in this region. We know that historically although we've held discussion groups with populations who are, really small populations, discussion groups are a pretty limited tool by itself. So, knowing that we've made efforts to engage populations who may be affected by, developmental delays, and other populations who are small in our region, it's difficult to be able to do that profoundly and meaningfully. So, one, we try to engage groups and discussion groups. I think probably the next evolution will be to say, how can we think about these 3-year cycles and say, let's do a big needs assessment 1 year, and then be able to, in the in-between years, be able to say, how could we create a more meaningful focus on 2 or 3 of our sort of very small populations who may have unique needs in the region, and do that well, as opposed to trying to merge it into a larger sort of global needs assessment for our region. I think that's probably our next advance. And we'll see how that goes. Would any of you who are interested in thinking about that, certainly, I know I would, Alice would, Elizabeth would be interested in talking about how to do that better.
Great. Thank you so much, Greg, for addressing that question. It's a tough one in 2 minutes, and we are just at the end of our time here. So on behalf of the Montshire Museum of Science, the Public Health Council of the Upper Valley, Dartmouth Hitchcock Norris Cotton Cancer Center, and Dartmouth Hitchcock Population Health, I'm Marco Staffney. I want to thank you for attending Health Research Live today. We look forward to future conversations about public health in the future. Thank you so much, everybody, and have a great afternoon.